We are good to begin, Dr. Nazneen.
Bismillahirrahmanirrahim. Assalamu alaikum. I would like to welcome all of our viewers who are joining from different parts of the world for today's webinar, which is being brought to you by IMI Women's Wing Connecticut chapter. And you are watching us live on Imamia Medic's international YouTube page, also known as My TV. So we'll begin the program with the recitation of holy verses. Bismillah ar-Rahman ar-Rahim. Inna atayna kal kausar. Fasalli li rabbika wanhar. Inna shaneaka huwal abtar. Sadaqallahul aliyul azim. As many of you know that IMI Women's Wing has been organizing health and wellness series since many years. And inshallah, we will continue this important initiative throughout the year. Inshallah. And before I introduce the moderator of today's webinar, I would like to mention that our audience can put up their questions in the comment section and we will share those questions with our speaker in question answer segment of the program. So without any further delay, I would like to introduce the moderator of today's webinar. She's a very important member of IMI Women's Wing, Dr. Sheba Zaidi. Just a minute. Dr. Shiva Zedi is board certified orthodontist and chair of IMI Women's Wing Connecticut chapter and the owner of 3 private practices in the Connecticut. A graduate of Tufts University School of Dental Medicine, she has dedicated her career to excellence in orthodontic care, mentoring colleagues, and advancing interdisciplinary education in dentistry. Dr. Zedi is passionate about empowering women in healthcare and serving the Shia community through faith, leadership, and service, all while balancing her role as a proud mother of 3, mashallah. Assalamu alaikum,
Yeah.
Dr.
Walaikum salam. Walaikum salam. So thank you for that introduction. Assalamu alaikum and good afternoon to everybody. I would like to welcome you to our Health and Wellness Series webinar, Autism Today, Facts, Trends, and Early Detection. With autism now affecting approximately 1 in 36 children in the United States, this topic is not only important, it's one that really impacts families, schools, communities every single day. We are truly honored to welcome a very remarkable duo. We have Dr. Saima Jaffrey, who is a board-certified pediatrician and assistant clinical professor at the University of Connecticut School of Medicine. She works on the front lines of pediatric care, helping families recognize early signs and access timely intervention, where early action can make a lifelong difference. Our second speaker today will be Dr. Mehreen Raza. Dr. Raza is a board-certified psychiatrist and an expert in child and adolescent psychiatry and an assistant professor at the University of Connecticut. She brings invaluable insight into the behavioral, emotional, and long-term dimensions of autism, helping us understand the full picture of care and support. Together, they bring pediatrics and psychiatry side by side, a very powerful collaborative lens that strengthens how we approach autism today. We encourage you to share your questions in the chat throughout the session. You, the audience, your engagement will make this conversation even more meaningful. And with that, let's lean in together and begin. I will now pass the baton to Dr. Saima Jaffrey. Dr. Saima.
Assalamu alaikum, everyone. Thank you very much, Dr. Huma, Dr. Sheba, Dr. Nazneen, Varda, the IMI crew, the Women's Wing, and all the audience, and especially to Dr. Mehreen, who is a dear friend and my cohort in helping me, and she with I with her, to battle not only medicine in general, but to help our fellow community members and trying to take on the suffering that maybe well babies, but also families might go through. And we try to make a difference one child at a time. So if I may, with no further ado, forward onto my slides. All right. I'm hoping everybody can see my slides. The basic topic for today, as Dr. Shiba so kindly gave us information on initially, is Autism Today, Facts, Trends, and Early Detection. This is a developmental, longitudinal, and multidisciplinary approach that we're going to be taking. Basically, the objectives of this meeting or discussion is to understand the developmental evaluation moving forward and how we address children with autism when a parent comes to your office or parents come to your office with concerns. We identify the red flags, early signs, understand what the screening and the referral pathways are, and how do we address it in a multidisciplinary fashion. The big picture. We have to understand that autism is a neurodevelopmental condition. You know, there are different types of neurological conditions. One is neurodegenerative. There are different other types of conditions that we know are involving the neurological picture. But in autism, it's a neurodevelopmental. You might hear words as neurodiversity, neurodiverse. This is a part of the definitions that they use. In addition, you will see that in autism, children with autism show social communication and interaction differences than the average child. There are restrictive and repetitive behaviors, and these symptoms are not a one-day sort of thing. This is not a child showing up with a cold. It's a child who is symptomatic and it's evolving over a period of time. We use a criteria, and Dr. Marine will go over this even more, but we have a booklet we call the Bible of Psychiatry, if you will. And we use this to define certain criteria or definitions of what we can define a certain illness as in the world of psychiatry. And we use this as our reference. So, in terms of autism, which I'm going to make it for just shortening the topic in terms of the words, ASD. ASD is defined in two categories. It's defined in terms of communication and in terms of repetition and restriction. So the communication part is when a child shows persistent reductions in social communication. And in this sort of presentation, the child shows social and emotional decrease in reciprocity. They're not reciprocating in the way they present themselves. If you show a reaction, they don't show an equal and opposite reaction to your actions towards them. They often are nonverbal in their communicative behaviors and interactions. And often they're developing, maintaining, and understanding relationships are different from an average typical child. Okay, they're presented as atypical. In terms of the restrictive repetitive behaviors, they show repetitive patterns of behavior and interests. They show stereotypical movements. You might see them stimming. You might see them doing repetitive behaviors in terms of lining up things. You might see them doing things like echolalia, which I'll go over in a little bit, where they repeat certain words over and over again, which is not parroting. You know, when we say, "Oh, how कितना cute लग रहा है," वो बार बार वही चीज बोल रहा है. "Oh, देखो कितना प्यारा लग रहा है, तोता बना हुआ है." This is not the tota wala cheese. This is more like they are repeating in an abnormal sort of fashion. So it's stereotypic in their way. Insistence on sameness. They are fixated on certain ritualized mannerisms, whether they're behavioral, they're verbal or nonverbal. Their behaviors are very restricted, very adamant in their fashion. Again, highly restrictive in their focus and in their mannerisms. Signs of autism. This is a little pictogram for you to understand how they also present. They present in hyperactivity, inattentiveness, rejection in physical contact. These children typically are very sensitive to touch. They don't want to be hugged. They don't want to be cuddled. They don't want to be rocked very frequently. Some do respond well to rocking, others want to rock themselves. You will often see the children come into the office and the parent will say, you know what? I all of a sudden notice they tiptoe. Parent will complain, I notice they tiptoe when they're on the rug, but they don't tiptoe when they're on the floor. That highlights to a parent or a physician, oh, they're tiptoeing. Not all children that tiptoe have autism, but that is one of the things that we make note of. They're sensitive to sounds. You'll see often children with autism cover their ears. And they don't like sounds. They might be scared of the vacuum. Again, not all children who are scared of vacuums. इसका मतलब नहीं है कि oh my God हमारा बच्चा scared है vacuum से. No, it's not the situation. But there are certain things in an autistic child जो उससे वो बच्चा जो है डरता है. In terms of hysteria, what temper tantrums, yes, it's not the terrible twos कि हर बच्चा जो है एकदम चीखने लगता है या जिद में आ जाता है ये वाला, it's not that either. This is hysteria beyond control. They're not consolable. उनको जो आप खामोश करने की कोशिश करें तो it's not that either. इसमें बच्चा जो है बिल्कुल उसमें चला जाता है कि हर हाल में चाहे आप कुछ भी करें वो बच्चा चाहे कैसे भी चाहे वो बच्चा calm down नहीं हो पा रहा है. And then there's signs of depression and isolation. वो आहिस्ता आहिस्ता बच्चा अपने आप को aloof कर देता है. बच्चा जो है they try to get away from things. They don't want to participate. They don't want to interact. वो खेलने लगता है तो अपने आप से खेलने लगता है या आमतौर पे जैसे स्कूल में चला जाएगा तो टीचर आपसे कहेगी कि नहीं ये बच्चा आपका जो है वो साथ में नहीं खेलता पैरेलल में खेलता है वो दूसरे बच्चों के साथ नहीं इंटरेक्ट करता है वो प्रेफर करता है कि अलग हो. What autism is not, this is also a part of the definition. It is not a cause of how a parent is raising the child. It's not if you're a mild parenting techniques or you're a soft parent or you're a helicopter parent. इसमें कोई ताल्लुक नहीं है of how you're bringing up or raising the child. It's not a part of nurturing कि आप बहुत सख्त parenting करते हैं या आप बहुत ही नरम parent है और आप हर चीज़ allow करते हैं. It has nothing to do with that. It is not caused by vaccines. आजकल propaganda हुआ हुआ है कि a lot of anti-vaxxers are putting out कि oh vaccine से हो रहा है, MMR से हो रहा है, chickenpox से vaccine से हो रहा है. It has nothing to do with vaccines. I'll go over that in a second. It is not diagnosed in one visit. Like I said earlier, it's an evolving sort of thing. And every child, it's presented differently. वो भी आपसे I'll go over in a moment. How birth history matters. Prenatal factors are important. How the pregnancy went, what happened during the pregnancy, what happened just immediately and around the pregnancy, what happened after the pregnancy, was the child admitted in the NICU, in the NICU, what was the family history, is the child premature, and what was the maternal health history. ये सारी चीजें बहुत जरूरी है जानना before we come up with the diagnosis. Again, जो मैंने कहा पहले, vaccines are not involved. You will hear it. अक्सर parents come, ज़रूरी है कि vaccines दें बच्चों को, बहुत ज़रूरी है क्या क्या ये families जो अक्सर आती हैं कि ओ मैंने सुना है ये मैंने ये देखा Google पे. Dr. Google is not the answer to all your questions. मैं आपको बताऊं, I've been doing this for 23 years. Vaccines are बहुत important and बहुत ही ज़रूरी in this whole situation. There were preservatives at one time in the vaccines. Those have been removed. The children now don't get preservatives in the vaccines, and there was thimerosal, which was a mercury preservative. वो भी हट गए हैं vaccine से. यहाँ तक they removed them even from the flu vaccine. It's not a vaccine issue at all. You will see that over and over again. You will go down a rabbit hole if you go and look up those things, but it has been proven over and over again, not vaccine related. It is genetically mediated. We don't know, we don't have our finger on it yet, but there is a genetic association. It is influenced by environmental, it's a epigenetic sort of situation. What we're finding is, does it have something to do with the plastics? Does it have to do with heavy metals? We're still trying to learn about it. So we know that it's involving genetic and environmental factors. ASD is a consequence of these cascading events that influence the environment, influence the developmental situation in the child, which then shows up in the way the child shows decreased attention in facial expression and social stimuli. We know now in identifying these children that we can show evidence, and there are three phases that we can pick it up in now. Prior to this, we used to be able to only pick it up when we used to see that child was only showing signs of deterioration or regression. Of Johei, we can see it now early on, evidence at birth. How? We see it when the child is now not making eye contact. The child is not smiling. We see a regression pattern where the child has started to make strides, started to talk, started to use words, and now all of a sudden the child is not doing that. अब बच्चा जो है बोलना शुरू कर दिया, अब वो वही अल्फाज हैं जो यूज कर रहा था, वो बच्चा अब वही अल्फाज अब नहीं बोल रहा है. And then you have where the bacha is now at a plateau. Bacha jo hai is now stopped at that level and aage nahi बढ़ रहा. वो bacha is not excelling in what they used to be able to do. पहले वो इतना अच्छा जा रहा था, अब वो एकदम रुक गया है. Parents are the best sources of that information. So as a physician, I look to my parents, and when they come to me with these concerns, I hold them as the best observers. After the parents, it's the school. The school will pick up those things. So it's very important. It's important also to realize that kabhi kabhi, just despite all of that, I make sure to keep an eye on the child throughout the visits when they come for their early childhood visits. Magar, on average, a child even today is diagnosed, could be early on, magar on average, it's by 4 years of age. And children in low-income families, they unfortunately are diagnosed later in life. एक चीज जरूर है, and that's very important to realize, that there's a large stigma. We know stigmas in mental health have been a major issue throughout medicine and throughout our mukhtalif cultures. Magar, it's very important to realize, just like asthma is a definition, just like diabetes is a definition, it is not a stigma to have a definition of autism or ASD. These children are brilliant. Jab I tell a parent कि देखें, it's so important to realize that these children are so importantly, if you give them the tools that they need, and you have those tools in your tool shed or in your toolbox, believe you me, ye children will be beyond smarter than the average child. I'll give you examples in a moment. Magar, these children are brilliant. They have spatial integrity and brilliance that other children of typical brain health and typical neurodevelopment are beyond that. They have visual and auditory perceptions that other children do not have. They will have intelligence that is beyond recognition. I can tell you, I have examples in my own office. दो बच्चे जो हैं twins हैं. एक बच्चा who's not even 3 yet, he can read words that are मेरे ऑफिस में होते हैं, जैसे it'll be written, it is advantageous, it is to their advantage to do this, it is for allergy's sake to do this and give them this antihistamine. वो बच्चा last week was sitting with his twin sister on the table. मैं दोनों को examine कर रही थी, and दोनों बच्चे बैठे हुए थे. बच्ची जो थी वो अपने टियारा और प्रिंसेस की बातें कर रही थी, और बच्चों जो था, he was rocking and he's reading the signs on the board on the wall, and he's like advantageous, allergic, antihistamine. Well, he's not even 3 years old. Or वो छोटी बच्ची जो थी, she was still on the Disney princesses. Or and I asked the mother, did you realize? She's like, I said, does your other child, your bachchi jo hai, does she read those words? She's like, no, no, she doesn't even know how to read. She doesn't even know her sight words yet. So this is the difference. वो बच्चा इतना ज़हीन है, and if he gets all the therapies he needs, I can tell you right now, he's going to be brilliant. Some famous people, आप सब जानते होंगे, are autistic. आप सब जानते हैं, everybody knows Albert Einstein. Who doesn't know Albert Einstein? If he was in today's society, and everybody knows he came up with the theory of relativity, he was autistic. If he came into my office, I would tell you, okay, even though he knows E equals MC squared, he falls into the definition of autism. Isaac Newton, the apple fell on his head and he came up with the diagnosis of, not the diagnosis, he came up with all those very famous equations that we all learn in grade school and in physics. Well, he was also autistic. Charles Darwin, who came up with the theory of evolution, he was autistic. He was known to be a person who did not want to go into conversations with people. He wanted to be isolated. And they're very famous actors and actresses. Anthony Hopkins, a very famous Sir Anthony Hopkins. Some of you who enjoy movies and British movies, he is a known autistic individual. And there are other many famous actors and actresses of today's society who are known. One, if you haven't had a chance to see, is the movie Rain Man, and that's why I put this up on the slide. Rain Man is another excellent movie to learn about autism and savants, and Dr. Marine will go over savants. And he was brilliant in mathematics, and his brother did not know about it, but I'm not going to give a spoiler. But please, if you get a chance, it's a movie from the 80s and 90s. Please, when you get a chance, do view it. Causes and risk factors, again, genetics plays a part of it. Children with siblings who have autism have a higher risk of autism. There are certain genetic conditions like Fragile X and tuberous sclerosis that have a higher incidence. Around the time of birth, if there are incidences, that also creates that risk of higher incidence of autism, as well as parents. If parents are older in age, that also causes a higher incidence of autism. In a nutshell, the best resource for anybody looking to look into autism any further is Autism Speaks. Some autistic people can speak while others are nonverbal, minimally verbal, and communicate in other ways, while some have intellectual disabilities and some others do not. Significant support in their daily lives, while others don't need support at all. The spectrum is so wide. So it's so important to know that. In the United States, as Dr. Shiba mentioned earlier, 1 in 31 children are diagnosed with autism. In Canada, the studies show that 1 in 50 children are diagnosed with autism. And we know that boys are 4 times more diagnosed than girls. Why boys more than girls? We believe that girls tend to camouflage with other diagnoses and tend to mask more frequently. And I had mentioned earlier, children of lower socioeconomic classes tend to show more often later in life. So this just gives you a conglomerate idea of what we look at when a child comes in. Baby comes in, I see the child, अक्सर I look, मैं अक्सर बच्चों से I start cooing. Oh, and mom and dad are इतने खुश होते हैं कि oh देखो कितनी अच्छी डॉक्टर है, हमारे बच्चे से कितने बातें करती है, कितना खेलती है, क्या इतना जबरदस्त जॉब है इनका, ये हमेशा खेलती रहती हैं बच्चों से। मगर असल में क्या होता है कि आई एम एक्चुअली नॉट ओनली प्लेइंग, ज़ाहिर है मैं एंजॉय तो करती हूँ, मगर द इशू इज आई एम एक्चुअली टेस्टिंग द बेबी। मैं बच्चों से मुस्कुराती हूँ, खेलती हूँ, आंखों से देखती हूँ। इवन व्हेन वी हैड विद कोविड मास्क पहनते थे हम लोग, I was actually testing, and believe you me, even with the mask, bache were able to discuss with me and interact with me, or वो आंखों से पता चलता था if the baby is actually autistic or not. तो बच्चा जो है, मैं अक्सर ओ मेरे बच्चा, ओ उर्दू में जब में बोलना होता था तो आई वुड स्पीक इन उर्दू, वरना इंग्लिश में ओ माय बेबी हाय हाउ आर यू, अच्छा मम्मा ने ये किया, अच्छा अच्छा। तो बच्चे एकदम सारे बोलने लगते हैं। 2 महीने से लेके 6 महीने तक मैं अक्सर cooing, crying and all that, वो बच्चा एकदम बातें करने लगता है। माँ बाप भी हैरान के ओह देखें आप तो आपसे बोलने लगता है, बच्चा बातें कर रहा है, ओहो। तो मुझे अंदाजा हो जाता है बच्चे स्माइलिंग, cooing, crying। अच्छा, जब बच्चा वो करने लगता है फिर मैं खिलौना देती हूँ, एंड आई से ओके ये बेबी के लिए है। वो बच्चा फिर आई गिव द खिलौना, बच्चा स्टार्ट्स टू रीच फॉर इट। बाय 6 मंथ्स बच्चा हाथ से, मेरे हाथ से ले लेता है, और बच्चा जो है एक दूसरे हाथ से वो करने लगता है। बच्चा फिर एकदम, मैं उनको पलट के उनके पेट पे लेटा देती हूँ, बच्चा एकदम मुझसे बातें करने लगता है ऑन देयर स्टमक। तो दीज आर ऑल इंटरेक्शंस दैट आई डू। अच्छा, बच्चा फिर मैं उनका नाम लेती हूँ। अगर बच्चा उनके अपने नाम से वो उन्हें पहचानता है तो मैं पूछती हूँ माँ बाप से, डू यू कॉल दम, अच्छा गुड्डी, अच्छा गुड्डी, गुड्डी आप, अच्छा बेबी, अच्छा अच्छा बेबी से पुकारती, बेबी बेबी। अच्छा, अगर बेबी फिर भी इज नॉट रिस्पॉन्डिंग, these are signs for me. If they're not responding to the name, are they not responding to my interaction? Are they having limited eye contact? Are they not smiling at me? Are they irritated by my touch? It's different if they're looking at something and now I'm showing something to the baby, and joint attention, for example, I'm showing it to a toddler, खिलौना दिखा रही हूँ, and the बच्चा is not asking or looking at the parent for recognition कि ये खिलौना मैं ले लूँ डॉक्टर से या नहीं लूँ. So now the interaction is between me, mom, dad, and the parent and the child. Are they saying इशारतन माँ बाप से कि मैं ले लूँ डॉक्टर से? थोड़े से झिझक है? Is there like hesitation? So that's important, because now this is the stage, 12 to 24 months, that they should have hesitation. Magar if the baby's just lying dull and not showing interaction, that's another sign. Acha, ab bachcha interact karne laga and they know me now because they've seen me quite enough. They know who I am. Is there gestures of uh, hesitation, or they have no idea what to do, and bilkul bachcha jo hai is constantly crying from my touch, and they're not even interacting well with the parent? Those are signs for me. Baby bachcha, jo I ask the parents, is the baby using words? Is the child saying certain words? Are they just saying mama baba, or are they saying mama cookie, mama mujhe cookie chahiye, mama dudu, mama ye chahiye, mama no? Or पहले कह रहे थे और अब बिल्कुल नहीं कह रहे हैं। पहले अपने आप को खड़ा करवाते थे अपना खड़े होके अपने काउच पे, या एकदम फ्लॉप कर जाते हैं। ये सारे signs are for me. Or are they trying to grab onto something from the parent? These are all red flags. Preschool years में, are they interacting, repeating words? आपने टेलीफोन दी बच्चे को, and I say, देखो baby, telephone. अब वो बच्चा is hearing and listening to the mom and saying telephone. अब वो बच्चा telephone लेके, but now we're asking, baby, do you want to eat something? और वो telephone, अब वो repeat कर रहा है। अब वो, it's not mimicking anymore. अब वो echolalia हो गया. They're repeating at the oddest times. वो बच्चा अब खाने के वक्त टेलीफोन, अब मुझे देख के टेलीफोन, अब वो किसी और चीज में टेलीफोन, हर चीज में टेलीफोन, and now it's not a normal repetition. It's out of the ordinary. It's echolalia, repeating words at the wrong time. Acha, sensitivities. I have children with autism who start getting sensitive. Um, with autism, they should not be sensitive to certain things, but then they have hypersensitivity and hypersensitivity to certain things that they don't want to touch. They have hypersensitivity to certain textures. They don't want to look at white foods. They don't want white sauces. They don't want certain types of puddings. They don't want, or they don't like certain grindy foods or textures of certain types of foods, but they do want um, to touch certain things in their everyday mannerisms. They want cotton. They start to dig out of their diaper, the cotton in the diaper. वो माँ बाप कोशिश कर रहे हैं not to touch the diaper, मगर they keep pulling out the diaper. And then रुई diaper का निकालने लगते हैं, carpet का रुई निकालने लगते हैं, and they want to touch it against their face. Other associated findings, they elope, they try to run away. They hurt themselves. They scratch themselves. Marine will go into this later. They headbang. You'll see children with severe instability and self-injurious behaviors. They fall. They don't feel that they get hurt. They injure themselves and it doesn't make a difference to them. They bite themselves, they scratch themselves, they headbang. You'll see some of the severe intellectual disability children, they have to wear helmets because they headbang so severely and they're not hurting themselves. A lot of these children, a lot of them are very active and are able to speak, and they're very intelligent and are able to do a lot of things, and some of them are not verbal at all. A lot of them, as I said earlier, sensory processing is a part of it. They're unable to process a lot of things, and then some of them are able to not process at all. They have sensitivities. They don't want their hair brushed. In terms of challenges, there are a lot of challenges that come along with it, and Marion will go into these comorbidities. They have ADHD, they have anxiety, they have depression. They can have chronic gastrointestinal, हमेशा उनका पेट खराब होता है. They have sleep issues. Sleep is a major problem with children with autistic disorder. They have issues with epilepsy and seizure disorder. They have other things also, and we have to rule these out when a child comes into my office. Or is there a hearing issue? Is that the problem? They might not be autistic. Is there a language delay? Is there a speech delay? Is it some other form of developmental delay? Is it intellectual disability of some other sort? Are they having issues with ADHD? Is that the actual underlying disorder, or is it masking the autism? Is there anxiety or trauma? Or is it sensory processing alone and separate from the autism? So my role as a pediatrician, I have to do a developmental survey. I have to do standardized screening. I have to make sure we're family centering it. I have to make sure we do the appropriate therapies, and I have to do the specialist referrals. What type of screenings I do when you come in? I do everyday pediatric referral testing, and we do PEDS testing initially throughout, but then we do the MCHAT, which is a modified checklist for autism at 18 and 24 months of age, and your pediatricians throughout US and Canada do the same. And then we do ages and stages questionnaires, and these are some other questionnaire tools that everybody does. And then there are guidelines that we follow. Like I said, I do play observation with the children. And then there are different levels of autism that require help, and then your children get labeled. And then Dr. Marine will go over that level 1, level 2, and level 3. Requiring help, requiring substantial help, or requiring even more substantial help. All right, again, testing tools. These are different. And then when the concern arises, I make sure that your child gets an audiology test to make sure hearing is not the issue. I make sure that we get early intervention if they're less than 3 years of age. We make sure they get referred to speech therapy, occupational therapy, physical therapy, and applied behavioral analysis. They teach the child how to do activities of daily living, which is important so that they can work and be active amongst their peers, so that they are able to do everything that a normal child without a typical child would do. All right, so that they can do everything as a normal child would. Because they're atypical, we want them to get to the level of typical activities. So eating, using the bathroom, speaking, activities, writing, reading, all the above. they would be able to come to the house, to the preschool, and then we refer to the specialists with follow up with the specialists. So that's where the developmental pediatrician comes, the psychologist, the neuropsychologist, the therapies come in, genetics, neurology, psychiatry. Dr. Marine would come in this part, a GI, sleep medicine. All right. Why is autism becoming so rampant, and why is because we're recognizing it now. The spectrum has become wide because we've added things like Asperger's into the spectrum. Before it had its own criteria, now we've added it into the spectrum. We're recognizing it more. We're diagnosing it more. Before, people who were not recognized, we're now saying, no, we're here to help and we're ready to accept it. We're not making it a stigma, and we know it crosses age, gender, and race and ethnicity. It can happen. We know it happens in Pakistanis. We know it happens in Indians, African Americans, Caucasians, Asians. I've seen the whole spectrum. Girls, boys, you name it. All right. And it's a family experience. We have to be there for the family. All right. Reassurance is key. All right. And then once this is diagnosed, school therapies are key. All right. Getting a 504 plan, guiding a individualized educational program for the child, and constant reassessment. All right. Prognosis, again, like I said, key. The prognosis is so important because once they get the therapies, your children will shine. I've had children who were not speaking, weren't able to say a word, and then now at 4 years of age, they're crawling into my lap, hugging me and saying, I love you, doctor. Makes a world of a difference, both for the parent and for me. It shows that it's so worth it. And now those very children are in college and they're computer programmers, they're economic majors, they're doing wonderful things. They can be Einstein. Key takeaways: it's a process, it's a long process, but you can do it. You can help someone in the community. We're here to help. And remember, great minds, not all think alike. And now I'm going to say thank you, and I pass it on to Dr. Marine.
Thank you, Saima. What a wonderful presentation. You said it all. Mashallah. No, it was really good. So, Assalamu alaikum, everyone. Thank you, IMI, and thank you all the audience for listening to us. So, as Dr. Saima just said, we get referrals from pediatricians, and I see patients in an inpatient also. So what is autism? Autism is actually a lifelong neurological and developmental condition. It affects how people interact with each other, communicate with each other, how they learn, and how they behave. So it's a full lifelong process, and we have to help them going through different transition at different age groups. And while we are doing that, their need arises for different therapies, different supportive environments. So they need social support, they need ongoing intervention, and they have educational need as they transition at different age level, and also in adulthood.
Sorry, Dr. Marine, sorry to interrupt you. Would you like me to put forward your presentation? Because we cannot see it.
Oh, you cannot see it?
Mm-hmm. I can share a screen if you'd like me to do that.
Please do that then.
Sure, sure. Just give me a moment, please. Please let me know. Is it visible to everybody?
Yes, but that's visible.
Sure. Okay. Thank you. We can go on, Dr. Marine.
Okay, so yes, I was talking about developmental disabilities that are associated with autism spectrum disorder. As Saima said, we have the full spectrum here. So it has core symptoms of autism and non-core symptom. Core symptoms are the social communication disorders and also repetitive disorders. And non-core symptoms are all those anxiety, ADHD, tics and Tourette, OCD, depression. And there are other comorbid conditions that come along with autism spectrum disorder that they are highly comorbid, which include epilepsy, sometimes psychosis or schizophrenias, and anxiety and depression. So what is autism? There is a problem in social responsiveness and communication. So these children, they are not up to that, like a neurotypical children, they are not socially responsive. And they lack in communication from the level of like not speaking at all to having deficits in communication. Sometimes autism occurs as a secondary symptom, and sometimes it's a primarily a genetic disorder, which when autism spectrum disorder is a primary disorder, it occurs with along with ADHD, OCD, tics, intellectual disability. Everything comes under it. Sometimes it's secondary to a genetic disorder or medical disorder like Fragile X or tuberous sclerosis. So as I said, that sometimes it has learning disability. So what is autism? What they are lacking? They are lacking theory of mind. What is theory of mind? Is being unable to see the other's point of view. They sometimes, unfortunately, can lack empathy. They have problem in executive functioning. They have problems in voluntary or automatic movement that occurs. So what happens that it can become these kids, because of these problems, they can be disruptive in the school environment, in the classroom, or they can be disruptive at home where they can show their aggression. So there the point comes when we have to actually treat them with medication. What is our role? Our role is to actually improve their functionality so that they can be independent as much as possible. So epilepsy is actually 40% comorbid with autism. We have to be sure that if there are any EEG abnormalities. So what we do, we run some lab tests that include blood tests, lead levels, or any other abnormalities there. Or we have to send them for EEG. Are there any EEG problems so that we can treat them with anticonvulsant medication? And sometimes the seizures are not happening, but actually having that abnormality can have some behavioral implications. So if we treat them, we can help them. OCD is actually very comorbid with autism spectrum disorder, obsessive compulsive problems when they repeat things, and that becomes sometimes problem because you cannot stop them from that. So there are treatments available for that. These children have circumscribed interests, meaning they are very rigid in their interests. They do not take the other's point of view. They just saying about their own interest. So what is the purpose of diagnosis? So purpose of diagnosis is at the research level, where we are actually inventing new tests so that we can diagnose these kids as early as 1 month old. So there is actually a new visual tracking system where we can track their visual track to see if this kid is autistic or not. And there is clinical. The diagnosis is about clinical. If they have comorbid symptoms of autism like ADHD, OCD, tics or Tourette, intellectual disability, or anxiety and depression, so that we can actually treat those symptoms. So that if we treat those symptoms, actually we can improve their behaviors in And in turn, we are helping the families, we're helping their educational need. And if their symptoms are in control, they can actually be having good behaviors and improve behaviors and improve learning. So another thing is insomnia, which is also very common with autism. These kids tend to fall asleep late, or there is early awakening. They sleep for very few hours. So we have research done on melatonin. And actually, melatonin is our natural hormone that releases from a pineal gland in our brain. So if we use that early on, we can get a better outcome with sleep. There is it's a grade A research evidence that we can use that and get help with insomnia. There is administrative level of autism diagnosis also, because these are the kids who need our help at every stage of their lives. And we have therapies available. We have diagnosis with ADOS, which is actually authentic diagnosis, which actually give that kid all the resources available in the state. And if you ask the school to do the neuropsychological testing, it's your right to get that testing. This is a very expensive testing, but if you ask the school, and the school should do that, all the good school systems, they have this system of doing the neuropsychological testing for them, and they diagnose them with ADOS. It's authentic testing, and they label them with, or they give them a diagnosis of autism spectrum disorder, and that's how they get all the resources. The first resource they get is ABA therapy, applied behavioral analysis, for the core symptom of autism. And the other non-core symptom you get along as you go with the referrals. Yeah, so that I just went over, like it's a continuum. The diagnosis is a continuum. You're from time to time, you need to test them for different things. The non-core symptom, actually, they come along as the child grow in age, and the behavior sometimes changes. They actually they are very sensitive to the changes. And any new school, new teacher, new therapist, new move, problem in the family, divorce, new siblings arrival, and loss of a family member, or what have you, these are the things that can trigger these kids. So when this happens, these kids can have temper tantrum or anxieties or depression. So there we get referrals, because these kids then can engage in self-harming behaviors like head banging, or self-harming, like they sometimes scratch themselves. They go and get to the point where they can actually they take the, sometimes it can get so bad that they can get the flesh out of their body. So it can really get bad in terms of self-harming behaviors. So there, fortunately, we don't see helmet kids anymore. You know why? Because there are so many medications that are FDA approved in children that can help them get help with those behaviors. Like antipsychotics are available. They're FDA approved to give for autism irritability. There is special term, autism irritability, meaning those kids they get aggressive easily. They throw temper tantrums, they throw themselves on the ground, and they injure themselves. So there are FDA approved medications now called aripiprazole, risperidone. We can give them in small dosages to help those behaviors. So as we discussed, as we talked with Dr. Saima, that we have a big spectrum now. Neurotypical is on one end, and neuroatypical or autism spectrum disorder on one end. It used to be Asperger also a part of it, but now everything is autism spectrum disorder. So why we did that? We did that in DSM-5, which is a new, relatively new. It came out in 2013. And we did that because we want to help all those kids. We don't want to leave any kid. Yeah. Okay. So, yeah. So, what is ABA therapy? ABA therapy is important at every level. They take your kid to the ground and they train them with everything. I was saying that before, that there is a term called pretend play. You give any child a bowl or spoon, or a girl a doll, she's going to be playing with the doll, right? And if you give a child a bowl and a spoon, they will pretend to eat from that. But autistic kids, they don't know. They're going to be flipping around the bowl, or they are lining up their toys or lining up their cars. So they have different way of looking. So what ABA therapy, applied behavioral analysis, do, they take the kid to the ground and the they actually practice every single thing with them. And it's a big thing to have more hours with ABA, because that's where you learn the behavior. And what we are going to do here is to take the child to the neurotypical level, where they automatically do the same thing. So it takes time, and they maybe the rhythm is slow, but they reach to certain level where they can be best functioning, independent, and working and learning. Yeah, I went over that there is a trajectory of symptoms. These are the non-core symptoms. The core symptoms are social and communicative problems, and repetitive movements, and restricted interest. Those are the core problems of autism. But we have a lot of non-core problems, which are all the psychiatric implications, and psychiatric diagnosis associated with autism spectrum disorder. There are SSRI medication that are antidepressant or anti-anxiety. They're very pro-social. They make your kids social. They have not a lot, not the best evidence is available for that, but if it helps somewhat, it can, that can make a difference in child's life. We want to help the families from each and every level. We want to help them navigate through the system. That's why we need that awareness in our community, so that we know that this is all available for your child. Yeah, I went over this ADHD and all the different comorbid disorders with autism, insomnia, and I mentioned that melatonin is a very big help. I've noticed that help, and it is available over the counter, and the dosages you can get a 6 milligram or 10 milligram. In that range, you can get that over the counter, and that helps. And you have, especially with melatonin, you have to give them with the start of the darkness, because that's a natural release of the melatonin in your brain. So these autistic kids, they are found to have little lack of melatonin. So we need, if we give them from early on, we can get some good response with sleep. Another comorbid condition is a schizophrenia or psychotic disorder. They are sometimes, there is a syndrome. They are mostly present in different syndromes. And unfortunately, and if that is the case, it's called childhood schizophrenia or very early childhood schizophrenia. They are sometimes present in velocardiofacial syndrome, and that has autism and schizophrenia comorbidity. And definitely when there is that with autism, it's a difficult diagnosis, because autism is also speaking less, and in schizophrenia there is problem with speech and problem with thoughts, and they are also very concrete. So there we need some genetic testing, and we find out through genetic testing, because they also have negativism problem with initiation, and they also have selective or total mutism. Yeah, thank you.
Thank you. Audience, the first question that they've asked, डॉक्टर सईमा, आपके लिए ये क्वेश्चन है। आपने वो स्लाइड दिखाई थी जो डिफरेंट सिम्टम्स थे, साइंस थे,
जी
सही है ना?
जी
वो एक पिक्चर थी। तो उसमें ये पूछना है कि उन साइंस में कितनी होनी चाहिए, क्योंकि माओ को तो होता है ना कि हमें लगता है कि हर चीज हमारे बच्चे को हो रही है, तो उसमें सब होना चाहिए या एक दो, क्या मतलब उसमें थोड़ा क्लेरिफाई कर दें।
Gee, no, actually, every child presents. You don't have to have all the signs. Some children, like I said, कि masking होती है कभी कभी ना, तो some children will present with only minimal signs because it's such a mild touch of the autistic tendencies, yeah, factors. And sometimes there is a what we call pervasive developmental delay. It's almost like autistic tendencies. तो उसमें they're kind of awkward. थोड़ी सी आप देखें, like I'm hoping आप लोग सब जाएंगे ना, आप लोग you're going to go to the Imam Barga, you're going to go to the mosque, and you're going to go see, and now आप सबके आंखें खुलेंगी, oh ये बच्चा थोड़ा सा different है, या ये बच्चा, I'm not saying to go and start diagnosing everybody, but you kind of get an idea. Like you'll see certain children are a little, or even amongst ourselves, you say someone is a little awkward, a little socially um, different. They have a hard time communicating. There's a little awkwardness in their behavior. Sometimes it's just the awkwardness, and that's all it is. Sometimes it is that they have a fixation and they are fixated on certain things. So no, they don't have to have every single thing. They
But
don't
is
have to
there
have
a rule like they have to have like half of the symptoms, one, two,
no,
or
no,
it could
it's
be just
not.
one or
It's
two is plenty?
the criteria. They have to have a communication issue and they have to have restriction and repetition. है ना? So if you look at the DSM-5 rules that मैंने दिखाई थी आपको, in one it was that you have to have the communication issue, that there is an awkwardness or a social interaction में there's something missing. And then there's also that restriction and repetition. Those are the classic signs, है ना? Now, what degree they show in, that's the difference, no? So and it could be very mild. It could be so mild that almost there's nothing, but it can be a part of it.
तो आपकी एडवाइस क्या है, जो माँ बाप हैं वो किस उम्र पे परेशान होना शुरू हो, और किसके पास, who should be the first person they approach?
The pediatrician, most
The
definitely. Pediatrician, why? Because the pediatrician, again, from birth through 21 years, 0 to 21 years, that pediatrician, if you're sticking to the same pediatrician, gets to know your child. Hannah, you're the first observer, but from birth to 21 years, they're the ones who are watching that child constantly with every childhood check. And so if you bring it up, you're watching. And then the school teachers are also watching. They're noticing things. Hannah. So if in the interim there is any issue, they will be able to pick it up. But the pediatrician is able to also assess in the process and be able to pick up those little awkward issues that are triggering in your mind. Is that something that I should watch out for? If it's something that there's a delay in speech, having trouble hearing, delay in, even it's sometimes some autistic children have trouble in motor function. And so is it a true motor function, or is it dyslexia, like Dr. Marine said? Is it dyslexia? Is it some other underlying,
थोड़ा समझाएं
mental
कि
disorder?
dyslexia का मतलब क्या है? What do you mean by dyslexia?
Dyslexia is when they are unable to read words in the right order, or they mix up the letters. So now they're having an issue and it looks like they're having a developmental delay, but actually they're unable to read properly because they're mixing up the letters or the words.
तो ये बच्चे आप क्या कहेंगी कि नॉर्मली आपको लग रहा है जैसे अपना बच्चा, हाँ आपको लग रहा है वो स्मार्ट है, लेकिन स्कूल में डू दे काइंड ऑफ फॉल बिहाइंड देन?
They do fall behind. Their grades start to affect, and now the child is showing signs of falling. Grades are going down, and they're having issues. And now the parent is coming to you and saying, "Oh my goodness, I don't know. His grades are getting worse, and I don't know what to do. I'm not sure if he has an issue. Is there a developmental issue? And then I most often, like Dr. Manning said, is we tell them to go get a neuropsych eval by the school. And that's something that all school guidance
हाँ,
counselors
right.
or
तो माशाल्लाह से बहुत questions आ रहे हैं, so I'll keep this
sure,
going.
sure.
This question again is for you. What is the restriction behavior in autism?
Restriction behavior, they are fixated, meaning they don't want you to touch them. They don't want you to hug them. They don't want you to cut their food up. If, some children will say, you make a pancake, they only want their pancake round. If aapne kaat diya, it'll throw them into a tantrum. That's restriction. They are fixated on certain things. Don't touch them. They put the four walls around them and they're encased in those four walls.
Is there a risk of having low IQ for kids with autism? Is the risk high or low compared to the average?
It's less than 3% for intellectual disability to a severe extent. So majority, like I said, are very within the normal range
No,
to
but when you
extremely
compare with,
intelligent.
let's say you compare the kids that have autism versus your neurotypical, is the IQ on an average the same? Is it slightly higher or is it slightly lower?
No, there actually only a slight percentage is not within normal. It's not an issue. That's why it's just, let me tell you it this way. And this is how I explain it to every family. The brain is working, all the wires are there. A typical child has all the wires and it's working fine. Atypical child with autism, the wires are all there, but they're all jumbled up. Now it's your and my responsibility to just pull those wires apart. Aista aista, if we help the child by pulling those wires apart and pulling out the kinks, they'll be functioning completely well. And that's the key.
This question is for Dr. Mehreen. Can adults be diagnosed with autism later in life?
Yes, so this is as we all said, that this is a lifelong condition. It's a neurological and developmental condition, and it's a lifelong. So these children that are diagnosed with autism, they are going through at every stage, they are neuroatypical, right? And they are transitioning into adulthood too. And sometimes it happens that especially in our countries, unfortunately, that sometimes it gets like it stays without diagnosis and they transition. The autistic kid, the children will grow into an adult, so it's going to be in adults too. I cannot hear you.
So आप ऐसी 3 साइंस बताएं कि आपका कोई एडल्ट है और उसको आप सस्पेक्ट कर रहे हैं ऑटिज्म है, तो ये कौन सी 3 साइंस हैं जो आप मतलब फाइंड करेंगे उनमें?
Oh, if first of all, I mean,
मतलब अलग होती हैं बच्चों से या सेम होती हैं?
same ongi, but at every stage you will have a different expectation. In children, their expectation is to go to school, come back, do this, eat, sleep. Adults, they are more actually in every area they will struggle, right? So the definition of autism is like problem with social functioning, problem with communication, problem with the restricted and repetitive behaviors, right? The same definition will go in every stage of life. So in adults also, you will find the problem with social functioning, problem with communication, and problem with restrictive interest and some repetitive behaviors, which can be like they are doing like they are rocking or they are flapping their hands. I mean those can be present or may be less pronounced, but they will struggle with social connection, and they will struggle with communication. So those are the same signs, but different stages of life, they have different expectations. So whenever the expectation, yeah.
Sorry, as a community, what can we do? What can we do to help families that are going through this?
Like with adults, of
no,
course,
with children or adults. I'm assuming we have more children that are being diagnosed. So how can we help?
Like acceptance.
Sure.
Accept, and then you have to help your child the best way you can. And meaning that getting all the appointments and getting all the resources
Right.
available.
But are there any special adaptations we can provide for them, if they come to Jafaria, to the mosque? Is there something we can do to make it easier for them? Or it doesn't matter?
I can say from our JIS school, where when we notice something, we are proud to talk to their parents, and Alhamdulillah, we counsel them, and their parents are also, they're bringing their children to Jafariya, so they are definitely looking after their children, and they are on top of everything. So I think that's the main thing. In adults, adults, they may have already established their care outside of Jafriya, but children, definitely, our role is to, if they don't know, we have to counsel them. We have to increase awareness, like we're doing on this platform. That's another platform.
Thank you. So as we conclude, I would like to extend my deepest gratitude to Dr. Saima Jaffrey and Dr. Mehreen Raza. You are, your expertise, compassion, and the care that you show, that is really very clear to us. Thank you to all the people that joined and participated. Your engagement reflects how much this topic matters to your community. On behalf of Imamia Medics, International Women's Wing, Connecticut chapter, thank you for being part of this meaningful conversation, and may we continue to lean, support, and learn from each other. Khuda Hafiz.
Shukriya. Khuda Hafiz.
Thank you. Khuda Hafiz.